Good afternoon, everybody. Thank you for joining us tonight for this webinar in the series of WPA webinars concerning psychopharmacology in the frame of the action plan of evidence-based psychopharmacology. Tonight we have two major figures in the field, two prominent speakers, Siegfried Casper and Michael Theis. We will start with Siegfried Casper, who will talk about the treatment-resistant depression from research to practice. Professor Casper is Professor Emeritus of Psychiatry and former chairman of the Department of Psychiatry and Psychotherapy at the Medical University of Vienna, Austria. Born in Salzburg, Austria, he was educated at the Medical School of the University of Innsbruck, Austria, and the Universities of Freiburg and Heidelberg in Germany. Dr. Casper gained clinical and research experience in psychiatry at the Central Institute of Mental Health, Mannheim, Germany, the Psychiatric Department of the University of Heidelberg, Germany, the Clinical Psychobiology branch of the National Institute of Mental Health, Bethesda, Maryland, USA, and the Psychiatric Department of the University of Bonn, Germany, in neurology at the Neurological Department of the University of Heidelberg in Mannheim, and psychotherapeutic and psychoanalytic training at the Adulthood for Psychotherapy and Psychoanalysis in Heidelberg, Mannheim, Germany. Dr. Casper published more than 600 papers in Medline, listed in Google, where his citation levels up to 50,000 and an index of 112. He participated in the authoring of more than 250 books or book chapters in various areas of psychiatry. He concentrates on the biological basis of mental disorders and their possible treatment approaches. Furthermore, he has conducted studies in psychopathology as well as in clinical areas. Dr. Casper is a frequent national and international speaker and continues to be actively involved in research programs studying depression, anxiety, psychosis, and dementia. Dr. Casper served on the executive committees and advisory boards of several national and international societies, such as the Austrian Association of Psychiatry, Psychotherapy, and Psychosomatics, the European College of Neuropsychopharmacology, and the European Psychiatric Association. He used to be president of the World Federation of Societies of Biological Psychiatry and honorary president of the WFSBP in 2013. Has been elected to the executive committee of the CIMP for the period of 2012 to 2018. And after this, he was president and now immediate past president of the society. Chaired several WPA sections, received the Aristotle's Gold Medal for his valuable contribution on mental health, and he is honorary and visiting professor in a number of universities around the world, which Siegfried, I will not mention them all. So Siegfried, the floor is yours.
Thank you very much, Kostas, and thank you very much, the president of the WPA, Afsat Javed, for inviting me together with my dear friend and colleague Michael Theis from the United States to talk about depression. It's my great pleasure talking to you from Vienna. I am Professor Emeritus of a large department and still working with patients now in my office and working also right now in our Brain Institute. So I will talk about the treatment-resistant depression, as you heard before from our distinguished chairman, Professor Fontoullakis, and I will talk about from research to practice. I will walk you through the different thoughts on this, and I'm very much looking forward for the discussion which you have. And please, I think you heard before, use the chat box to put in the questions when I talk, so that we can summarize them at the end. And if I cannot answer all of these questions, if there are too many, don't worry, then I will answer them by email if you connect with the email. Before I start my presentation, as usual, I would like to give you my potential conflict of interest, which includes also a number of new medication, which we use for treatment-resistant depression throughout my presentation. Let me show you one publication which I recently was invited by the European College of Neuropsychopharmacology on the topic, is treatment-resistant depression really resistant? And in this small paper, I described that we psychiatrists have sometimes strange diagnoses. And if you think about internal medicine, there is no treatment-resistant diabetes or treatment-resistant hypertonia, because specifically in depression we have now very good treatments, which I show you later, and this is a rather old concept for treatment-resistant depression, and I think we should change these wordings to some extent, although I have more than 100 publications probably on the title of this topic. I think, like oncology, we should talk about stage 1, stage 2, stage 3, stage 4. So for treatment-resistant depression, it would be stage 3 depression. I also mention here the terminology which is used in different publications, like insufficient response. You're probably aware that the American FDA, the Food and Drug Administration, and the European counterpart, the EMA, European Medicines Agency, granted also indication for some atypical antipsychotics like quetiapine, then aripiprazole, or the combination of olanzapine together with fluoxetine as an insufficient response to treatment. That would be not responding to one treatment. So treatment-resistant depression is usually used when patients do not respond to 2 treatments. That was also in the development program of the Janssen development program for then S-Ketamine, and also was then used in our European group, which I show you later. And treatment refractory is termed usually if the patients did not respond to 3 or 4 or more trials. Usually these patients undergo electroconvulsive therapy, or when, if available, also to some brain implantation of different probes. Chronic depression would be another term which I describe here, when the patients are for 2 years depressed. That would be chronic depression. What I also describe here, and what you see throughout my presentation, is the European program for treatment-resistant depression. You see, I use this term now in my talk all the time, and I was reminded, like over 20 years ago, it was an ECNP, European College of Neuropsychopharmacology meeting, when we sat together with colleagues, Professor Mendlevich, then Professor Montgomery, Professor Serretti, and Professor Zuari, that the definition of depression got too broad, like major depression is too broad, and we were looking for a more biologically defined type of depression. And we said, why don't we look at treatment-resistant depression? And we defined it that the patients do not respond to 2 treatment modalities. And that was the origin of the European network for treatment-resistant depression, a biologically oriented approach. What I also discuss in this paper is then the last development on the so-called psychedelics. And I mention again, psychedelics is a very bad wording, because usually patients, when you ask them about psychotropic medication, they say, oh, you get dependent from these antidepressants and this changes your personality. And with psychedelics, you even have then hallucinations. So this is another very bad wording. And I remind the audience then on this paper on the neuroscience-based nomenclature, a joint approach spearheaded by Professor Sohar, that the medication should be named based on the mechanism of action, like SSRI, SNRIs, or then for the D2, 5-HT2 antagonists. And for the psychedelics, it could be, for instance, 5-HT2 agonistic properties. So please, if you want, have a look at this short paper. And since this meeting is also an objective meeting with learning objectives, I hope at the completion of these activities, you should be able to explain confusing terminology related to TRD. TRD stands for treatment-resistant depression, identify risk factors for TRD, and discuss pharmacotherapy augmentation strategies and novel approaches in treatment-resistant depression. Let's start with the definition. Here on the right-hand side, you see the European program, the GSRD, it's called the Group for the Study of Resistant Depression, as it has been spearheaded by the different centers, and the Medical University of Vienna is one of the leading centers, and we include patients from Belgium, from France, from Switzerland, from Germany, from Italy, from Greece, and also from Tel Aviv. So we include now over 3,000 patients. This slide is a little bit older because we just finished the fourth wave of patients. And the specificity of this group is that patients are recruited in university and non-university centers, including inpatients and outpatients. We do not have any exclusion criteria like you have usually in randomized controlled trials. So suicidality on one hand side, mental or somatic comorbidities are not excluded, and therefore we think it reflects a real world sample how the doctors see their patients in everyday clinical practice. We are very happy that we could influence the EMA, the European Medicines Agency, that to adapt our diagnosis of treatment-resistant depression, which you see on the next slide. So it's a failure of at least 2 consecutive treatments with the antidepressants of the same or different class. Before, EMA said, no, it has to be a different class. But you know, when you start with the SSRI, what choices do you have? The norepinephrine reuptake inhibitor, reboxetine, is not available in a number of countries, or like the norepinephrine dopamine reuptake inhibitor, bupropion, is also not available in some of these countries. And we showed, based on our database, that there is no advantage if you go to different classes. So it can't be the same class. Then it's taken for sufficient time, 4 weeks, in a sufficient dosage, and patients should be adherent to therapy. In clinical, this is a research and the EMA definition. In clinical practice, very likely you would look at plasma levels of the medication, if the patient is an ultra-rapid metabolizer, and probably you might also look at some genetic variables if the patients have a specific cytochrome problem to have this ultra-rapid metabolizing activity. What are the risk factors? In our paper in the Acta Psychiatrica Scandinavica, we took together one group of patients which we examined like from 2004 to 2010, and then took another independent sample of this, and by machine learning, that's a computer technique which takes not into account all different kind of hierarchies. It just compares where do you find which factors fit together. And we could identify that the prominent risk factors are symptom severity, suicidal risk, higher number of lifetime depressive episodes, or comorbid anxiety disorders. You are experienced psychiatrists, and you very likely would agree that these factors you would also acknowledge, but I think it has not been shown from a large European sample. So further risk factors are psychotic symptoms, higher number of previous antidepressants, which of course goes along with longer duration of the current episode, and higher number of lifetime depressive episodes, and inpatient status. Dr. Marley from Australia, at very much the same time, put together a paper where he also found these factors And he concluded by excluding overlapping, comorbid or conflating diagnosis, the heterogeneity of the TRD patient population may be reduced. These clinical variables are very easy to obtain. I do not present you today genetic data of our sample, which we also looked at, but all of these genetic data are beaten by far from the clinical data. So we find some statistical associations with the 5-HT2A receptor or with the serotonin transporter polymorphism, but usually this just explains 2 to 3% of the variance, whereas these risk factors which I showed here, they explain 70 to 80% of the variance. Let's jump over the ocean to the North American STAR-D study with regard to anxiety. And you see here, this is published by our North American colleagues, and where Michael Theis was also a very eminent figure in this publication. When you take on the left-hand side the response and the right-hand side the remission, and you look at anxious depression versus non-anxious depression, you see that anxious depression have a worse response and a worse remission criterion. Response is a 50% reduction of response, and remission would be a Hamilton score below 7 or a Montgomery-Åsberg scale below 10. So very similar findings in two populations which you can probably compare. In our European sample, when we looked at suicidality, and we could demonstrate if the patients have more suicidality measured by the Hamilton Depression Score, you see moderate and severe suicidality, you find higher bars of the resistance in those patients. So suicidality is a very important issue also, that patients get a treatment-resistant depression. A very important finding also from the STAR-D study, again, I would like to mention also our good friend Michael Theis, who participated substantially in this study. You see here on this graph the treatment steps, step 1, step 2, step 3, step 4, and you see on the y-axis the percentage of patients, and you see with every step you get a worse response, and with every step you get a worse also remission criteria. This is very important because later at the second part of my talk, I show you some data for Ascatamine, for the NMDA receptor antagonist, which actually took patients at the third step and still had a very good treatment response. So keep in mind, you have to treat your patients at the beginning already very effectively with the right medication. And if the patients unfortunately come to the third step, then use the best medication which is available. And most European countries have now included this in their treatment programs. There are still some monetary issues being discussed. So let's start with the next slide. I have to push here. And to summarize my thoughts, which I just gave to you, you probably saw this slide already in different publications. There's a first-line treatment, usually with SSRI or SNRI. Then second-line treatment, usually doctors add on some medication, or if there is no response at all, they switch the medication. If they do this, still 1/3 of patients with major depressive disorder become treatment resistant. Nowadays in university or tertiary referral center, they usually see treatment resistant depression because the first line treatment is usually done by primary care psychiatrists, second line by psychiatrists, and then the patients are sent to the hospital. At least that's the situation in Europe. What are the consequences of failing of more than 2 treatment lines? That's a summary of some publications which have been published here. You have more comorbidities. I showed you the psychiatric comorbidities with anxiety disorders, but you have also somatic comorbidities with hypertension, diabetes, heart failure. You have a 2 times as high hospitalization rate, and you have a 36% longer mean hospital length of stay, and most importantly, a 7-fold increase in suicide rate if the patients did not respond to at least 2 treatment modalities. Needless to say, major depressive disorder is a brain disorder. Coming from Vienna, you might expect some psychoanalytic thoughts, but I tell you, if Sigmund Freud would live nowadays, he would be very happy to discuss these different mechanisms. And as a matter of fact, in 1896, he wrote already that I wish we would have a natural medicine which has more of these mechanisms of action which will destroy all our theories about this. The brain is exposed to stress, genetic vulnerability, to trauma, but also viral infection. We know, for instance, that the COVID-19 viral infection, of course, goes also to the brain and causes some brain changes. These changes are then related to a dysregulation of neural circuitry, and we speak from default mode network. There are neuroendocrine, autonomic and immune dysregulation changes. In the older days, we looked at neuroendocrine changes. I just would like to mention the hypercortisolemia, and nowadays we speak also about the neurotrophic support, specifically if we talk about the NMDA receptors. The clinician is confronted on the right-hand side with the symptoms of depression, like depression, anxiety, emotional, cognitive, behavioral, and physical symptoms. And quite often, the doctors, they do not have the feedback thought that this is a brain disorder, because they work with all these phenomenological things like depression, anxiety. But we always, specifically if we give medication, but also if we do psychotherapy, we should be sure that we treat the brain also when we do some psychosocial treatments with them. And finally, the brain should be more stable. That's our aim. Again, this is another slide which shows the neurobiological underpinnings of major depressive disorder. I cannot go into all these theories, but I would like to mention the neurogenesis and the synaptogenesis is a new understanding of major depression, specifically if we think about the new types of medication which are nowadays used for treatment-resistant depression with a fast mechanism of action. Here you see the evolution of antidepressants, and you're probably aware that Professor Kuhn from Switzerland published in 1957 the first antidepressants, imipramine, in German language, in the Swiss Medical Wochenschrift, and thereafter it was also published in the American Journal of Psychiatry. From these days onwards, the tricyclics came just on the market, also the irreversible MAO inhibitors, and like a big revolution, the SSRIs came in the 80s, all different SSRIs, and luckily we have also a further development with the dual acting or with the agomelatine or the vortioxetine, but the new kids on the block are S-Ketamine on the one hand side, going to NMDA receptor, or brexanolol and zuranolol going on the GABA receptor and the extra synaptic GABA receptors, and the unfortunately word of psychedelics, which should be changed. And you see also a number of medication which might not be available in your different countries. And I heard we are over 400 participants from different doctors all over the world. So you might not find all of this medication available in your country, but keep in mind the mechanism of action of the older have a broad spectrum actions, a multiple action, then it changed to more single active agents like the SSRIs, and then to multimodal mechanism of action, and some completely new mechanism of action like esketamine, brexanolol, or the word of psychedelics. Sometimes it's thought that psychotropic medication doesn't work so good like medicine used for internal medicine. So we should be very thankful to Professor Leucht from the Technical University of Munich to publish in 2012 a large meta-analysis of 91 trials, meta-analysis of somatic diseases, and compared it with meta-analysis for psychiatric disorders. The open circles would be those medicines used in general medicine and the closed circles for psychiatric medicine. And you see, they work the same. As a matter of fact, when you take the numbers, the psychiatric medication seem to work even better. So I think we should be proud that we have a good medication which works. Let me also relate to the literature. You find when you read papers the wording of combination, augmentation, or add-on. The combination augmentation wording is usually used in Europe, and our North American colleagues say, oh, Siegfried, are not so difficult. If you add something on, it's an add-on medication. Well, usually combination means two antidepressants like SSRI plus mirtazapine. I would like to remind you, doctors did it a long time ago before the study of Pierre Blier published in the American Journal of Psychiatry to show that you add SSRIs and mirtazapine, you have a better response. I would like to mention also if you add trazodone, you also have a better response. Augmentation would be if you give an antidepressant with another agent like lithium or second generation antipsychotics. But we know that lithium has also antidepressant properties, and second generation antipsychotics like quetiapine have been also good for treatment of depression. So this combination augmentation is probably not a very good wording. I prefer add-on, but specifically for S-Ketamine and other NMDA antagonists, the add-on approach is used in the literature. Let me tell you what's going on in Europe. We did a pharmacoepidemiological cross-sectional multi-center study together with the colleagues from different parts of Europe. And here you see what kind of medication did the patient get in addition to antidepressants. You see 1/3 got benzodiazepines. So this clearly hints that we should look more in the GABA receptor because 1/3 of the patients additionally needed benzodiazepines. 29% got other antidepressants, antipsychotics 24%. If you just take the inpatients, the figure for antipsychotics goes up to 50%. So this is a mean of all the different in and out patients. When you ask which antidepressants are combined, you see SARI, that would be trazodone, and NASA would be then mirtazapine. So half of the patients, they got SSRIs or SNRIs plus the SARI or NASA. This is insofar interesting because we know all Stephen Stahl's textbook where he very nicely showed the pharmacodynamic properties of the different medication and showed clearly you add another mechanism of action, like with the NASA, you add the 5-HT2 blocking activity and also some noradrenergic activity with the SARI, with trazodone, 5-HT2 blocking, 5-HT1A agonist properties, and also some prefrontal dopaminergic activity. Second generation antipsychotics are used for augmentation. Well, quetiapine has been thoroughly studied, and in Europe it's the only one who got the indication for insufficient response. In North America, olanzapine also got it in combination with fluoxetine, and aripiprazole in the US, which did not get authorization in Europe because the company could not provide long-term data. But in Europe, you see it's also used, but to a lower extent. The question is, what is lithium and second generation antipsychotics doing? I understand in North America you do not use lithium to a large extent. Keep in mind all of these were unipolar depressed patients, no bipolar patients in there. And we looked retrospectively what was the outcome of the antipsychotics versus lithium. The antipsychotics were those which you just saw before, quetiapine, olanzapine, and so on. And you see in the dark bars, that's the second generation antipsychotics, and the light blue bars were lithium. That was significantly advantageous for the second generation augmentation. So Antipsychotics work better than lithium in unipolar depressed patients. What about the S-Ketamine nasal spray? We took the database, which was sent to the FDA and contained all second-generation antipsychotics like aripiprazole, brexpiprazole, cariprazine, olanzapine, and quetiapine, and compared it to the database which has been sent to the FDA for esketamine. And for effect sizes, you see that the effect size is about double as high for esketamine than for the second generation antipsychotics. So for clinical reasons, please keep in mind second generation antipsychotics beat lithium and esketamine beat second generation antipsychotics. That would be also my clinical view on the augmentation add-on strategies. Alan Young at the Institute of Psychiatry in London at the same time put together a network meta-analysis of 27 trials. He summarized this, that mood stabilizers have a low level of evidence, that's mainly lithium, antipsychotics, medium level of evidence, and NMDA antagonist, which is esketamine, high level of evidence. So we didn't know from each other's work, but similar finding, and that would also be my clinical take-home message to the audience. March 2019 was a great day for psychopharmacology because we had suddenly a new medication available. I would like to say also in psychiatry, not only in rheumatology, oncology, or diabetology. So it's good that we have a new medication available. It was the FDA release, and the EMA, they accepted it on the same database. It took in half a year later. The publications of ketamine and esketamine, they rose steadily from 2010 onwards. And you're probably aware, before 2010, the NMDA antagonist was studied also in schizophrenia, but soon it emerged, well, this is probably not the right approach. Probably we should go to the... That reminded me also on the old days when Ronald Kuhn first looked at imipramine in schizophrenia, and then he said, well, it doesn't really work in schizophrenia, but it works in depression. And you are aware, imipramine is a derivative of chlorpromazine, so these medications are pretty much the same chemical structure. So medical depression is a disorder of synaptic plasticity. This is the new way of thinking. And you see on the upper panel, if you stress an animal, then you have a loss of different synapses. And if you treat them with NMDA antagonist, then you have more spine density and branching complexity. So Yale University, also Hong Kong University, put this very nice together. And you see on the lower part of this panel, then you see there are more synapses. I think a very educational slide where you can tell the patients, well, it's a disorder and it is also then treated with a biological basis. These are animal data. And in Vienna, we are lucky at pretty much the same time we did a study on SMRI and fMRI study, a pharmaco-MRI study, and looked at esketamine versus placebo in a balanced crossover design. We took very low dosage of esketamine intravenously because we thought when we take higher dosages, then we would break the blind pretty much. So, and we looked at different structures and we could find an increase of hippocampal volume, esketamine versus placebo, already after 65 minutes. That's about the time frame when the patient also says, well, doctor, I'm feeling better. Of course, we cannot look in the brain of humans like you saw before on animal data. Here you see, but we interpret it in this paper. It can be related to treatment-induced spine density of pyramidal neurons, also in the prefrontal cortex and also in the hippocampus. So that's, to my understanding, one of the first also human studies to show this very clearly, published recently in Translational Psychiatry. You probably saw this also, that on the left-hand side you find the traditional SSRI approach, and the right-hand side you find the medication which target glutamate. I would like to use this slide also that the new medication do not replace the old medication as yet, because all the studies have been done on top of SSRIs or SNRIs. So when we give SSRIs or SNRI, we know that the monoamine transporter in our depressed patients is of lower density, corresponding to lower synaptic availability of serotonin. But if we add glutamate medication, then we have increased BDNF release, we have increased synaptic function and strength, and increased synaptic density. These are the theories based on animal research, but these synapses do not behave very differently also in humans. So it's an extra mechanism of action which you add when you give a glutamatergic compound. Quite early, we looked already in the serotonin system, and with positron emission tomography, we looked if ketamine binds to the serotonin transporter in humans, because we are aware that when the SSRIs came on the market, of course, nobody really understood the mechanism of action thoroughly in the 80s, 90s, and then some patients with the serotonin syndrome came out, and we looked at the serotonin transporter with PET ligands, and we could measure no measurable binding to the SERT transporter when we gave a dosage which is usually used 0.5 milligram per kilogram intravenously. But we were aware that there are animal studies which showed at higher concentrations, like if you use 800 milligrams, which is used in anesthesia, then you might find some binding in the serotonin transporter. We published also on a clinical level that you can use the NMDA receptor antagonist esketamine or ketamine together with irreversible Mayo inhibitors, so the patients didn't have any knowledgeable side effects. Together with colleagues from Europe, Wiesla Kubola from Poland, Andrea Fagiolini from Italy, Josie Ramos Quiroga from Spain, Daniel Suri from Belgium, and Alan Young from the Institute of Psychiatry in the UK, we put together some recommendations on the management of treatment-resistant depression with S-Ketamine nasal spray. We summarized the basic science, the evidence-based knowledge, and the expert guidance. And we summarized that S-Ketamine is a promising, novel, and fast-acting treatment for treatment-resistant depression. But nevertheless, we need more real-world data to add to the existing knowledge. So it's a start, and we all know that this is a quite good treatment, but should not block further research in this area. There are a number of research questions which we probably can address then during the Q&A session. On a clinical level, where might S-Ketamine nasal spray fit in the treatment pathway? At the beginning, I told you already that there's a first-line treatment, second-line treatment, third-line treatment. So you see on the green bar to the right, it's a third-line treatment. So some doctors might ask, oh, Professor Kasper, don't you believe in this medication? Well, I believe in this medication, but I also say I believe in science. It has been always studied as a third-line treatment, and because patients should not respond to the first antidepressant given, not to the second antidepressant given, and then as a third-line treatment. So future studies might show us if this can be also used to an earlier stage. Of course, in the practical situation, if the patient responded 1 year very good or 2 years ago to S-Ketamine treatment, you shouldn't say, well, dear patient, we have to wait until you do not respond to 2 antidepressant treatment modalities. I would give him the S-Ketamine spray or the intravenous one right away, like I would do with patients who told me, well, doctor, I always responded very good to electroconvulsive therapy, so we would give them also electroconvulsive therapy. So this is one understanding how this should be elaborated in the future. You're probably aware that in the studies, there was always, when the S-Ketamine was used, the doctors were forced to start a new medication and add the S-Ketamine nasal spray. This was done by the ethics committees to ask the doctors, well, you cannot expose the patient to two treatment modalities who do not work. And therefore, the practical recommendation would be, if the patient doesn't have no response at all to the second course of the treatment, you should switch to a new SSRI and S-Ketamine nasal spray. But quite often the patient has a partial response to the second course of treatment, then you can continue with the same medication and add S-Ketamine nasal spray. You see, this is a clinical interpretation of the data, how it should be done, because doctors usually do not switch medication. And so that would be a clinical take-home message based on this publication. In the last part of my talk, I would like to tackle a little bit the psychedelics and give you the definition. Psychedelics should not cause physical addiction, craving, delirium, produce thought, mood, or perceptual changes. So the experiences are similar to dreams, religious experiences, acute psychosis. There are two groups, the tryptamine derivatives or the phenylamines. Tryptamine derivatives are LSD, psilocybin, or ayahuasca, and the phenylethylamines would be the mescaline medication. It has been shown in different studies, and the University of Zurich, for instance, did a large number of studies, but also the Institute of Psychiatry, together with Mr. Harris and also David Nutt, did a large number of studies, and they've, of course, found there's a default mode network, so a change in the network, and that the 5-HT2A receptors are associated with higher level functions in human cortex. There is no question that this medication tackles the 5-HT2A receptor in an agonistic way. Remember, the second generation antipsychotics, they block the 5-HT2A receptor. This is an agonistic receptor, and therefore it has a larger also suggestibility and also hallucinations. Here you see the connectivity. So in normal, you have normal default mode network, and in manic states you have a hyperconnectivity, and here in depression you have a disconnectivity. So it should work for the disconnectivity, as it has been shown in different publications. On a clinical level, I would like to show you a few studies which have been published, and more to come, of course. And you see the numbers are very small, like 12 patients. There's no question that if you agonistic tackle the 5-HT2A receptor, you have a good antidepressant response. It was well tolerated, and it was also safe and effective. And some patients had an effect up to 6 months. This was astonishing. And another study is a psilocybin assisted therapy. On a methodological point, this is discussed because one group, you see, had a waiting list, like is done usually in psychotherapy studies. But all of the patients know, well, if you take psilocybin, you have hallucinations. And in a waiting list, of course, they didn't get anything. So on the right-hand side, in the upper panel, you see delayed treatment and immediate treatment, delayed treatment, no effect in immediate treatment, a good effect. So again, no question, but again, this had very low numbers of patients, just 27 patients in the group. Another study comparing it with escitalopram, also a low number of studies, like 30 in each group. So there was advantageous to escitalopram and no statistical difference between these two groups. Again, I would like to summarize. The wording is very bad for having as a psychedelic, and no question it works. However, the side effects are quite important, and to my understanding, should not be used for a therapeutical outcome. So here you see once more the increased connectivity, and the colleagues, they say, well, this increased connectivity should show you new insights into behavior and memories. This reminds me on the old days in the 70s when there was this primary scream therapy where patients were sitting in boxes and screamed and had new experiences, but definitely did not help them to change the whole situation. For me, it's quite clear that this dissociation with psychedelics is a side effect, and future development should develop psychedelics which do not have this side effect. And as a matter of fact, there is a question of dosing or a question of, for instance, retarded formulation nowadays under research. And definitely it should not be viewed as a supervised trip, because that would put psychiatrists out of medicine. And I'm sure Sigmund Freud would not like this also at all, to have these thoughts evoked with this medication. Give me one clinical example. If a patient comes with an alcohol level of like 2 promille, of course the patient has also side effects, and he talks about a lot of things he would never talk about when he would not be drunk, and nobody comes to the understanding that should be used therapeutically. But interestingly, now some doctors and also publications say, well, it should be used to better understand the unconscious of the patient. So it's a clear side effect to my understanding. So let me conclude. What do we know about psychedelics? It works in depression, it works in PTSD, no question. There's a rational mechanism of action. Interestingly, a growing social pressure for legalization, and the industry is behind it. What we do not know, how to manage expectations, what dosage could we use, what a role of microdosing, what about the long-term safety and tolerability, should be add-on or monotherapy, and are perceptual changes therapeutically meaningful or only adverse effects? Coming back to Esketamine, for instance, for Esketamine, the dissociation which you have in Esketamine, which is not a psychedelic, of course, right? But it clearly has shown that this is a side effect and not related to any outcome message. In the publications of the psychedelics of psilocybin, there is, to my understanding, an unscientific mix of theories. On the one hand side, which nobody questions, the activation of 5-HT2A receptors, and then suddenly come some old-fashioned psychoanalytic insights that a therapeutic window should be opened to facilitate insight and emotional release, and that leads to unconscious processing. And very astonishing, the colleagues even write it should lead to altered brain functioning and even anatomy. So this is really amazing. And keep in mind, when a patient comes drunk to you, you never would say, well, now we look into your unconscious processing. You just would say, well, you're drunk and probably tomorrow you forgot everything. With this, I show you a slide with the new area of fast-acting drug developments, and the important stuff is in the middle. You don't see any monoamine structures like serotonin transporter or 5-HT2 receptor antagonists or some other monoaminergic mechanisms. You always find NMDA receptor, GABA receptor modulator, or glutamate releaser. Esketamine has made it already on the market. Brexanolol partly on the market in the US, not in Europe. Then Laniseprime has also positive results by now. And so we have to wait for the next future. But the most important thing that we know about the monoamine structure, but now we go to a new area, which is the NMDA receptor and the GABA receptor, which hopefully helps us to treat the patients more effectively. Let me summarize the key points. Treatment-resistant depression is a very common subgroup of depression, is often overlooked or attributed falsely to psychosocial variables, and poor patients, they are tortured with thoughts what should be wrong in their psychosocial environment. New pharmacological strategies include the glutamatergic as well as the GABAergic system. That's completely new, because remember that in Doctors quite often say, well, don't use the benzodiazepines because they are not good for you. Well, 1/3 of the European patients in depression get this medication, and the brexanolone, which I didn't talk today, goes to the extrasynaptic benzodiazepine receptors, which should be quite different. Psychedelics need to be studied further. Again, it's not a very good wording. The hallucinations of this group of medication should be handled as side effects and not used therapeutically. Please remember the analogy to alcohol, drunken state. And new pharmacological strategies does not mean that the old ones do not work. We have now this new medication as an add-on medication to the old medication. With this, I would like to show you one piece of paper which we put together in Austria, English version of treatment-resistant depression, diagnosis and treatment. Please write me, and I'm happy to send you this English version. Of course, the original version is available in German language, and we hope that we could summarize all the important points in this publication. With this, I thank you very much for your attention, and I hope you could get together a number of questions which I see already in the chat box. Thank you very much.
Thank you, Siegfried. That was a very comprehensive, very detailed presentation. I personally enjoyed your comment on psychoanalytical psychopharmacology. Something I was thinking a few years ago. Now we have a number of questions. The first is there any explanation pertaining to the very rapid effect for Esketamine?
I'm sorry, addictive effects, yes? Okay.
Very rapid effect
okay.
of Esketamine.
Compared to SSRIs is a rapid response. As you see, also the anatomical analogon would be that you have these rapid changes in the brain structures, like the hippocampus, which I showed you before. So since I saw a large number of patients, then usually when they get this infusion or when they get the nasal spray, then they want to be left alone. They're in a hyper-aesthetic situation. So you have to avoid all different kind of noises of the street or walking on the floor. And usually after 2 to 3 hours, the patients are doing much better already.
Do you think genotyping is something we should use as a routine in clinical practice?
Well, genotyping is not as yet there, but my successor in the German department, Professor Ruiescu, he's a very good geneticist. I hope he finds out some genetic findings. Right now, I would only recommend genetic typing with regard to the cytochrome P450 system to tackle the ultra-rapid metabolizer, which you probably also find as a first step when you measure blood levels. So I would only look at the cytochrome system, the P450 system, not at the other receptors. But I know there are companies promoting quite a bit the genetic typing, which is not cheap, like 1,000 euros usually, right? But it cannot be used in everyday praxis as yet.
How about the use of Esketamine in the long-term maintenance and prophylactic phase? Is it possible?
Yes, for the long term, it follows pretty much the course what we have for electroconvulsive therapy. Usually we start with 2 times a week. I recommend like Tuesdays and Thursdays in a hospital setting, for instance, because then you see the patients on Friday and you prepare everything on Monday. And then you do it for 4 to 6 weeks. And then for the next 6 weeks, you do it once a week. And then thereafter, you come to the continuation phase, and you can do it every 2 weeks or every 3 weeks. And the data available now are up to 1 year. And this is pretty much the same like you do with electroconvulsive therapy, and it has been shown to be a safe and effective treatment.
The last question is whether Esketamine can be used in bipolar depression.
Yes, it's a very important issue also. Esketamine nasal spray has not been studied in bipolar depression. However, with the intravenous formulation, we published a paper together with our colleagues in Poland, with Janusz Rybakowski and his department. And there is a good understanding that you can treat also bipolar depression with ketamine or esketamine. And however, most importantly, you need to leave in the mood stabilizer. If you get rid of the mood stabilizer, lithium or carbamazepine, then soon, very likely, you might have a manic phase. So please leave in the mood stabilizer, which is one of these medication or atypical antipsychotics, and on top of it, use the ketamine or esketamine approach, which has been shown to be quite beneficial. But the nasal spray has not been studied as yet for this indication.
Thank you again, Victor. We will now proceed with our second prominent speaker, Professor Michael Face, who will talk about the pharmacotherapy of depression and guideline-based strategies for initial and long-term benefits. Michael Face is professor of psychiatry in the Department of Psychiatry of the Perelman School of Medicine of the University of Pennsylvania, and is also a member of the research faculty of the Corporal Michael Grenzer Veterans Affairs Medical Center in Philadelphia. In 1979, he graduated from the Ohio State University College of Medicine. He completed the internship, residency, chief residency, and postdoctoral training at the University of Pittsburgh Medical Center, where he subsequently rose to the rank of professor of psychiatry and chief of the Division of Academic Adult Psychiatry before moving to Philadelphia in 2007. A distinguished life fellow of the American Psychiatric Association, Professor Face is renowned as a teacher, mentor, administrator, researcher, and clinician. He has been elected to the membership of the American College of Psychiatrists, the American College of Neuropsychopharmacology, and Penn Medicine's Academy of Master Clinicians, and is a past president of the American Society of Clinical Psychopharmacology. He is a founding fellow of the Academy of Cognitive Therapy and member of advisory boards for the Anxiety and Depressive Disorders Association, the National Network of Depression Centers, the Depression and Bipolar Support Alliance, and the American Foundation for Suicidal Prevention. One of the world's most highly cited psychiatrists, Professor Face has authored more than 1,000 peer-reviewed publications and book chapters, including a number of citation classics. The award-winning Learning Cognitive Therapy is among the 18 books that he has authored, co-authored, or co-edited. Professor Faye's research has been continuously funded by federal agencies since the mid-1980s and currently focuses on novel psychopharmacotherapies for difficult to treat depressive disorders, as well as strategies to improve the dissemination and implementation of cost-effective forms of cognitive behavioral therapy. Professor Thais Michael, the floor is yours. We are very proud of having you here with us tonight.
Thank you for the kind invitation to be here today. I am speaking from sunny Arizona, and that's one reason why the sky is so bright behind me. I'm delighted to be here with you. It is always a pleasure to share a speaking engagement with Professor Casper. And Kostas, thank you for that very kind introduction. My talk has been shortened a little bit because there's been some overlap with material that Professor Casper has talked with you about already. I'm going to go ahead and share my screen. So here I am, and I'm going to focus primarily on first-line treatment and then talk about the blur between the transition from first line to second line, the area right before you begin to talk about people having treatment-resistant depression. I have a large number of relationships with the pharmaceutical industry. Disclosure is part of the way of managing the potential for conflicts of interest, and here is a partial list. No pharmaceutical support was involved in the preparation of today's presentation, although some of the things I'll be talking about are studies that I've led or participated in, and your own involvement, of course, has a potential conflict of interest. I'll also note that even my marriage involves disclosure of a conflict of interest, as you can see below. So we all know depression is one of the world's great public health problems. Across the world, the point prevalence is about 8%, but it increases and decreases in various countries. And when you combine major depressive disorder, bipolar disorder, the minor depressive disorders all together, you may have a point prevalence as high as 14%. It's the greatest cause of workplace disability in the advanced economies of the world, and it's a highly comorbid condition, frequently with patients having anxiety disorders, post-traumatic stress disorder, and substance use disorders complicating. It is a condition that will exaggerate or amplify the disease burden of all chronic medical conditions, and it hastens mortality associated with these conditions. And then finally, about 3/4 of all of those who die by suicide have a depressive disorder of some form or another. And into the pandemic, suicide rates, particularly in younger patients, have been increasing throughout the world. One of the reasons why depression is such a important condition is that it now often begins before age 30. So people might spend 2/3 of their life having depression. Two correlates that are associated with more treatment difficulty, anxiety and bipolarity, are associated with an earlier age of onset. In many parts of the world, getting people into treatment is a problem, and untreated depression is a risk factor for becoming chronically ill. But even for those who get treatment, about 1/3 will not remit within the first year of continued therapy. So we have high risk of chronicity, and then for those who we treat successfully, we have further risk of relapse or recurrence. We'll talk about that towards the end of this presentation. In some parts of the world, depression continues to be a highly stigmatized condition. In others, it's only a somewhat stigmatized condition. Because depression can alienate or wear out social support structures, and low social support is a risk factor for depression, you see some further risk for chronicity. And of course, the depressive state is associated with a lower level of motivation, a higher level of hopelessness that inhibit treatment seeking, and also increase the risk of not adhering to recommended treatment. So if we think about the major influential practice guidelines and try to synthesize what we have circa June of 2022, we have a large number of antidepressants, most of which are now available in what we call generic or no longer branded or inexpensive forms. We also have a handful of very good focused time-limited psychotherapies that are not so widely available and are not largely in generic form. So there is some difficulty in access to psychotherapy. Although well-done psychotherapy across 8 to 12 weeks has about the same chance of benefit as well-done pharmacotherapy across 4 to 8 weeks. So pharmacotherapy has an advantage in terms of availability, in terms of access, and in terms of speed of onset. Psychotherapy has the advantage of course, fewer side effects, and in some parts of the world, a higher level of preference. In the United States, people say they would prefer to avoid taking medication and see a psychotherapist, at least for a first course of treatment, if that is possible. I think importantly, we as psychiatrists favor pharmacotherapy when patient severity is high, particularly when patients have psychotic features or a marked melancholic kind of depression, when there's grave disability. So urgency or improvement, and of course, when our patient is disabled or grossly impaired by their depressive symptoms. In some parts of the world, as many as 1 in 3 people who are treated for depression also receive a benzodiazepine, although this practice is no longer broadly encouraged, and we no longer even really study it, although the effort is needed to help have better methods to discontinue or to taper and minimize the use of benzodiazepines for reasons we'll talk about later. Many psychiatrists favor the combination of psychotherapy and pharmacotherapy, and there is evidence of added benefit, perhaps on average 10 to 15% greater benefit, better chance of remission, particularly among those with chronic or severe or more complicated illnesses. As I mentioned above, access to care for psychotherapy is spotty. And I have to tell you a not too secret, and that is that a large proportion of the good we do, whether it's pharmacotherapy or psychotherapy, builds on the patient's own natural history, their own prognostic likelihood of getting better with support. And a fairly significant portion of the so-called placebo response really represents the patient's ability to engage in a helping relationship and work out of their depression, whether the vehicle of that work is pharmacologic or psychotherapeutic. I was asked to talk about the pharmacotherapy of depression, so this will be my last slide on psychotherapy. I just want to point out that over 12 to 16 weeks, cognitive behavior therapy, interpersonal psychotherapy, and the behavioral activation focused forms of behavior therapy have data, replicated data, that are comparable to that of antidepressants. I believe that patient preference is a strong moderator, that people should have first the treatment they prefer, and you should avoid treatments that are unpreferred, at least at first. And all of the forms of psychotherapy really have certain active common ingredients like restoring morale, helping people get moving again and engaging again, and solving the problems that have been overwhelming, or at least managing the problems better, or obtaining help to solve the problems. You can quite inexpensively enhance the value of pharmacotherapy or psychotherapy by adding increased physical activity, such as brisk walking, or even aerobic exercise programs, which have measured additive benefit. And indeed, as I pointed out, when you add psychotherapy to pharmacotherapy, you can both target certain residual symptoms and add about a 10 to 15% chance of benefit. So let's talk about contemporary best practice guidelines for how to do a course of depression, knowing that among our participants today, there are important differences in what is possible and what is available. Let's start with the notion that aside from ketamine and S-Ketamine, that generally our first line treatments need 4 to 8 weeks to see if they're going to be sufficiently effective. And this assumes that the treatment is tolerable. Obviously, if the treatment is not well tolerated, you discontinue much sooner. During those initial weeks of treatment, you want to make sure that you've provided education, or we call it psychoeducation, about both the illness that we're treating and the nature of the treatment that we've picked. Ideally, it's good to have consensus between you and your patient, shared decision-making if possible, about why we picked this treatment as opposed to that treatment. It is good to have in place a way to know for sure that the prescription has been filled. In one study in the US, 10% of antidepressant prescriptions were never filled. It's another good idea to know if the prescription was refilled. Because obviously a 4-week prescription, if it's refilled every 6 to 8 weeks, is not being taken the way the medicine is prescribed. And in an ideal world, I like to see my patients every other week until they are responding. I know in some settings it is not possible to see people more often than once a month. Now, in the modern era, there are support vehicles, web-based methods that can be used to facilitate electronic check-ins as a way of keeping track of symptom reduction, side effects, and adherence. I think these are outstanding. If you don't have that available, even telephone-based with office assistants doing the checking in and the collecting the self-report information Our patients tell us we don't ask often enough about their side effects, and we don't do enough about their side effects when they tell us. So a clear recommendation is to listen and learn. And so we do need to be more concerned about our side effects than about our patient side effects than we have been in the past. And our aim is to have a symptomatic remission if humanly possible. And by that, I mean a level of signs and symptoms of depression indistinguishable from someone who's never been depressed, and functional recovery if possible. And by this, I mean recovering to the person's premorbid baseline for their ability to work and love and partner and befriend. So another piece of advice I can give is to work through your treatment algorithms briskly and to generally optimize that initial trial before switching. And our patients tell us that the thing they like the least about their antidepressants are that they don't work well enough. That was the number one area of frustration in the survey. And number two were the side effects of the medication. And so if you just take those two issues, not working well enough and side effects, you are accounting for more than 80% of the expressed dissatisfaction of the depressed patients that we treat. And here are the side effects that they like the least. Weight gain, sexual dysfunction, and fatigue. Those are the ones that really get in the way. And then below that, feeling edgy or on edge, insomnia, and then some of the classic side effects way down at the bottom, such as a dry mouth. So another newer aspect, and by newer I mean just over the last 20 years of improving the care, is the recognition that an infrequent visit at a physician's office is not the best way to get people better. And so 3 models of care that overlap have been introduced. One is called measurement-based care, in which simple, valid symptom assessments and straightforward ways of asking about and recording side effects are implemented into the visits. Now, collaborative care involves measurement-based care, as well as then engaging nurses, care managers, therapists, other office assistants into the care process so that patients can be checked on, adherence can be ascertained, and progress can be learned about more quickly. And so the third one is a process called shared decision-making, which of course is entirely blendable with measurement-based care and collaborative care, in which the prescriber learns a way of engaging the patient in the decision-making so that the patient leaves the office feeling more confident that the treatment that they've agreed to give a try is a treatment that makes sense and that it's one that they have been a part of and learning about and then ultimately choosing. So here's what we got to offer. Our treatments have limited specific efficacy. And by that, I mean in placebo-controlled trials going all the way back to 1980, let's say, that the real advantage of one of your favorite drugs over its placebo is only about a 15% average. And so if the placebo got a 35% response rate in a study, the drug of your choice may have only gotten a 50% response rate in that study. If you think about this very cynically, the placebo accounts for 60% of the benefit. There's no need to be cynical because there is no placebo unless the care is being provided, and that's the engagement with the physician, the prescriber. And so this is my point. The care that you provide has more to do with the patient getting better than the actual decision you make about the antidepressant. That doesn't mean the decision's unimportant. It means the care you provide is that much more important. Always keep in your mind that any medicine you pick in the real world has about a 10% chance of failing because of one or another of tolerable side effects. Some medicines are better than others, but the range from the best tolerated to the least tolerated is only about a 50% kind of range. Our favorite antidepressants aren't especially good for some kinds of anxiety, for some kinds of insomnia, or for sharpening or improving cognition. These are among 3 of the most common residual symptoms. Often we need to add adjunctive treatment to deal with these persistent residual symptoms. And our treatments are slow. They take weeks to show their effects, not days, again, with the exception of ketamine and S-Ketamine. And this most likely is related to the way they interact with monoamine systems. Changes at the receptor level need to be translated through second messengers to changes in gene activity. And these in turn need to rein in discrepancies in neural circuits. And this process with conventional pharmacotherapy takes time, the very same way the process of learning a psychotherapy and engaging and problem solving take time. As I mentioned in the outset, the time it takes for an antidepressant to work just happens to be faster than the time it takes to learn and implement a psychotherapy. As Dr. Casper said, there are some people who don't respond to anything that we have, and those are often said to have refractory depression. And as Dr. Casper also said, about 20 to 30% of our patients don't respond to anything in our first and second line of therapies. And for want of a better name, these people have been called, has been said to suffer from treatment-resistant depression. I'm not going to spend any additional time on that other than to say one last time that many of these people will respond to medications with other mechanisms of action. Some of those, such as ketamine and S-Ketamine, are now becoming available. So we've had a lot of new antidepressants introduced over the last 40 years, and the tricyclics and the monoamine oxidase inhibitors have now moved down to third or fourth line therapies in most parts of the world. But the point I want to make here is across 3 generations of antidepressants, 40 years of research, they've not gotten better in terms of benefit. In fact, the drug placebo differences are slightly smaller in the modern era than they were, say, at 1980. And this is because you'll notice there has been a slow growth in the placebo response. There are many reasons for that, too complex to talk about today, other than to say the newer antidepressants are safer and somewhat different, and generally a little more tolerable, but they are not inherently better in terms of getting people to response and then ideally to remission. So in North America, the Canadian practice guidelines have been the most recently updated and reflect a lot of the options we have to offer. My own professional organization, the American Psychiatric Association, has not started work yet on the new depression practice guideline, although it's next up. Our current one, published in 2010, is getting, as we say in English, long in the tooth, meaning quite old for many purposes. But medications are normally now divided into first line, second line, third line, primarily because of their safety and ease of use. And so you'll notice tricyclics in a second line position, MAOIs in a third line position. Throughout much of the world, the first line consists of selective serotonin reuptake inhibitors, or SSRIs, SNRIs, or the serotonin norepinephrine reuptake inhibitors. In some parts of the world, but particularly North America, bupropion is a widely used first-line medicine. And in Europe and the United States and Canada, mirtazapine, which is a tetracyclic-like structure, more related to older antidepressants than newer ones, is considered a first-line medicine because it is inherently safer in overdose than tricyclic antidepressants. And because of its sedative and appetite-enhancing properties, often reserved for more severe depression, and particularly in older patients, as a first-line agent. There are always other newer generation antidepressants that have been around long enough for which accessibility and cost concerns have been addressed that join the first line. And you'll notice in the CANMAT guidelines, vortioxetine is listed as a first line antidepressant for just that purpose. In the United States, it is still considered a second or third line agent because you have to go through kind of prior authorization and showing that other treatments haven't worked in order to have access to it. at the end of the day, no matter where you're practicing, you pick an antidepressant because of your own experience with it, your sense that it's going to be a good match for what the patient is suffering from. And this is a belief and a habit, not a fact, but it's your personal choice that you drive. Cost influences what you choose to pick. And your notion about is this going to be an easy and available medicine for your patient. So we don't have any real good scientific ways of matching antidepressants with our patients. But what we do have in the last 10 years is a little trick that if you're doing measurement-based care, you can know with fairly high certainty when a treatment is going to fail and when you might opt out of the decision process to stay the 6 or 8 weeks with a particular therapy. And that is that for people who are not going to respond to an antidepressant, the vast majority of them have shown minimum or no improvement during the first 2 weeks of therapy. And if you just pick a number, let's say 20%, if you have less than 20% reduction in your symptoms at the end of 2 weeks of therapy, there's about a 90% chance you won't respond to that treatment. And so if you think about it the other way, if you stick with that treatment over the next 4 to 6 weeks, your patient has a 10% chance of benefit. And that's simply, you can do so much better with anything else that you might pick at that point. So here's one really good reason to use measurement-based care, and that is you can move away from, you can opt out of a likely to be ineffective therapy after only 2 weeks if you know that the patient is having no benefit. Of course, you also move away from a therapy that has too many side effects from the patient, and the sooner for that, the better. So that's not a positive predictive fact, it's a negative predictive fact, but it's still important. It doesn't mean if your patient has 25% after 2 weeks, they're going to get better. It simply means that they have at least a 60, 70% chance of getting better if they're moving in that direction. So you do need to continue to follow patients. So let's say that you've gotten to 6, 8 weeks. Your patient has not benefited. They've not had the 50% plus improvement. They're not making progress, or they're right at the edge of a response, but they've got too many side effects for you to do much more about it. You always want to make sure that your patients adhere to the prescribed therapy, that they're not drinking too much, or that they're not using too many other drugs that are probably getting in the way of the medicine having the chance to work, that they're not suffering from some other condition, whether it's medical or psychiatric, that might be influencing the likelihood. So you just want to think through the very same things you thought through the first time around to make sure that you're on the right track. And it's iterative. You learn from your experience. You define what symptoms are better and what symptoms haven't changed. And you go through in your thinking list, what do I have that I possibly can prescribe instead of, or in addition to, that can address how much trouble the person is still having. And this can include psychotherapy as an adjunctive treatment in addition to pharmacotherapy. So even though we talk about response and non-response as if they're dichotomous or binary entities, you can see here from the STAR*D study that Dr. Casper talked about that if you look at how people do with a first-line therapy, here it was citalopram, optimized 12 weeks, optimized to up to 60 milligrams in this study. You can see that there is a long tail to this curve. And if you have a good visual imagination, you might actually see 3 modes of outcomes, a desirable outcome, an intermediate outcome, and a poor outcome. But when we talk about non-responders, we're talking about a heterogeneous or diverse group. And of course, whenever you have heterogeneity, you do not have a one-size-fits-all approach. And if you look at the symptoms that characterize our non-responders or our incompletely remitted patients, they're all over the DSM-3-9 criteria. It can be any number of these persistent symptoms that continue to get in the way. So let's look at our practice guidelines. So when we think about going from first line to second line, what does our practice guideline tell us? Well, most of the guidelines encourage us to do the best job we can with the first line of treatment. We'll call that optimizing. Some guidelines like switching to another antidepressant, other guidelines don't. I'll come back to that in a moment. The process of combining antidepressants has grown more popular with the greater safety of our current antidepressants. I'll have a slide on that. And when we decide that we don't want to combine antidepressants or we don't want to switch, we have a number of options for augmentation or adjunctive therapy. So the first question, should we switch or should we combine or should we use an adjunct? Switching is the most straightforward and simplest thing to do. Adjunctive is the easiest to do. It is easier not to stop a medicine and up-titrate another. It is easier to add something. There's no doubt about that. And unfortunately, the STAR-D study didn't answer the question, although I'm going to show you a slide that you sort of saw in Dr. Casper's talk, just to make my point that in the 3 treatment levels of STAR-D, the group that got an adjunctive treatment always did better than the group that was switched to another treatment. And there is a little secret for that, and that is that this was not a randomized decision, that the doctor-patient dyads were allowed some leeway in picking the choices they got. And the doctors and patients favored switching when the first treatment was bad, when the first treatment was ineffective and poorly tolerated. They favored the adjunctive strategies when the first treatment was reasonably well tolerated and somewhat helpful. So it is almost an apples and orange comparison. But if you'll notice, the drop in the popularity of switching versus using an adjunct was really reflected in the practice guideline written more recently, and including the World Federation of Societies of Biological Psychiatry, which Dr. Casper was one of the authors of. So for people who got some benefit and who have reasonable tolerability, combining antidepressants has become the most popular strategy at this point in time, because it doesn't involve cross titration. It involves adding a known entity that is somewhat different than the first antidepressant to try to enhance the effects. And this is no longer thought to be a bad practice, although you do need to know about what drug-drug interactions or drug-drug gene interactions might be relevant to the particular combination that you're using. And across the world, the most popular second medicine to add is mirtazapine. In North America and a few countries in Europe, bupropion is the more popular of the adjunctive strategies. Bupropion, of course, has no serotonergic effects other than the fact that it might slow the metabolism of some SSRIs, increasing their blood levels. Only mirtazapine has the benefit of having multiple controlled studies showing that this is actually an effective trial. One common mistake when you use adjunctive or when you use combination strategies is that, well, am I not going backwards? Okay, I'm just going to move on quickly ahead because I have taken myself in the wrong direction in my talk, but I will come back and catch up. That you just want to make sure when you're using a combination of strategies that you make sure that you have adequate drug exposure. You use therapeutic doses of both medications, unless you're doing blood level monitoring, which is rarely done today, or unless you're taking into account a metabolic drug-drug interaction. Now, what is the role of benzodiazepines as an adjunct? Well, I would say if the patient has marked anxiety or if they came to you on a benzodiazepine, those are the two potential combinations. When we add adjunctive benzodiazepines, they can improve early symptom improvement. If we're using a benzodiazepine sedative hypnotic, that can similarly hasten benefit, but we do not really have great evidence after 6 to 8 weeks that this is a good long-term combination. And we have growing concerns about ultimately not just the liability for abuse, which is modest, Only about 5% of benzodiazepine initiations of therapy end up in people having some difficulty with it. But there is tolerance of effects. There is drug-drug interactions that are worrisome, including worrisome interactions with alcohol and more recently with opiates. And for the older patients, even people as young as Dr. Casper and me, benzodiazepines will increase your risk of falling and have been associated with hastening the risk of dementia. And in epidemiologic data sets, people who take benzodiazepines are at increased risk for chronicity of depression. Interestingly, anxiety, which is a risk factor for non-response, as you heard from Dr. Casper, anxiety that develops or gets worse on an antidepressant may actually be a harbinger or an early warning sign that instead of having unipolar depression, your patient may have a depression in the bipolar spectrum. So I look at anxiety or depression made worse in an anxious, agitated way as a potential clue that I may need to treat this patient as if he or she has a bipolar spectrum disorder. And of course, with DSM-3, we have the subtype now of with mixed features, which accounts for about 25% of all depressive episodes. And one strategy that we might use instead of a benzodiazepine for such a patient, made worse, not better, with an antidepressant, would be to add a newer generation antipsychotic. And these strategies are the most common of the adjunctive strategies now used in some countries, such as the United States. They work quickly. There are a lot of them that work. Even medicines that have very little pharmacologic similarity have about the same potential for benefit. And so there is a very good chance, 10-15% above placebo, that your patient will be feeling a lot better within a week or two when you start an adjunctive newer generation antipsychotic. But there are questions here associated with this benefit. And that is, we don't have good empirical guidance as far as how long to use these medications. And we've got real side effect concerns with extended therapy, including weight gain and other metabolic side effects, and ultimately a risk of tardive dyskinesia. In our long-term studies with aripiprazole, we found that the risk of tardive dyskinesia was less than 1 per 100 patients per year, more on the order of 6 per 1,000 patients per year. But that was not an older group. The risk would likely be higher in late life depression. And I can't tell you the risk was in the second year or third year or fourth year of therapy, because our study didn't go on that long. I can tell you that 15, 20, 25% of patients who are on an adjunctive newer generation antipsychotic over a year or more will pick up a significant amount of weight gain, let's say on the order of an average of 5 kilograms. And this needs to be watched very, very carefully. So we've gotten our patient better with a first-line medication, a second-line medication, or a second-line strategy that involves combining or augmenting. And now we're moving on into the longer-term model of therapy. And so again, we don't want to declare victory at response. We want to keep tweaking, keep working, and to help the person get to remission. And by convention, when a remission is sustained and stable over some number of months, some guidelines suggest 2, others take it to 6. Over some number of months, we can say that the person is recovered. But look, we know from longer term studies of antidepressants that whether you're recently remitted or recovered, if the antidepressant strategy is reduced or stopped within those initial 6-9 months, that you do have a chance of suffering a relapse or a recurrence. And for this reason, models of continuation therapy and maintenance phase therapy have been introduced. So just to make sure we're on the same wavelength about the natural history of depression, most people recover within 3 to 9 months of the onset of depression. But even if that is true, Your chances of relapse and recurrent are relatively common. One of the leading risk factors for relapse is incomplete remission. One of the leading risk factors for recurrence is prior episodes. And either case, relapse or recurrence, is associated with a real worsening in your lifetime prognosis. So we now recommend continuation therapy of 6 to 9 months duration for virtually all antidepressant responders. And you can think of some odd scenario that you would not recommend continuation phase therapy, but for almost everybody, when you have the benefit of the treatment, you want to continue it for 6 to 9 months. And in STAR-D, the more steps it took for you to get better, the greater the risk that you would have a relapse or recurrence. So the harder you've had to work to get the patient better, the more vigilant you need to be as you move from the acute phase of treatment to the maintenance, to the continuation phase. And this, I think, is an important time to think about the sequencing effects of antidepressant, of adding psychotherapy or an adjunctive antidepressant approach, maybe even lithium salt, when you have a patient who's at grievous risk for relapse. Now, here's an even scarier graph. This is counting the number of previous lifetime episodes, and then here you're watching a survival analysis of the risk of recurrent illness. And goodness gracious, you can see that each number of lifetime episodes, all the way out to 15, you can't tell the difference between 10 or 15 prior episodes, but there is a progressive risk in the likelihood of recurrent illness unless you have maintenance phase pharmacotherapy. So this is very sobering data on the need for maintenance phase pharmacotherapy. So here are some guidelines for maintenance phase therapy. If your patient has 3 or more lifetime episodes or 2 or more episodes within the last 5 years, you should recommend an indefinite course of maintenance therapy. And just to be clear on our use of English, here I'm talking about indefinite, not meaning lifetime. I do not know what's ahead in my lifetime, let alone the lifetime of someone who's 25 or 30 years old. But indefinite means as far as I can see. As long as I perceive the benefit to exceed the risk, and as long as I can persuade my patient through shared decision-making to share this, we're going to continue this medication with periodic reassessment. And by periodic, I mean twice a year, once a year, something like that. I will only reduce the dose with great reluctance when I have a reason to do so, such as difficulty reaching an orgasm or the possibility of medication causing weight gain. So dose reduction is associated with some increase in the risk of recurrence. So do it with caution. There is a belief that there is a process, a neuropharmacologic process called tachyphylaxis, as if it's a fact. However, when we look at relapse curves from our controlled studies, the most parsimonious, the most credible explanation for the apparent failure of a drug that you thought was effective was, number one, the patient is not adhering to it. Number two, the patient didn't really respond to the medicine in the first place. They had gotten a placebo response that we attributed to the drug, and now we're seeing that placebo effect fading. Or number three, the patient's condition has changed, either psychiatrically or medically. I think the last guideline I want to recommend for long-term treatment is keep a weight chart. Always ask about side effects, and there really are late emerging side effects other than weight gain that you do need to be mindful of. So I hope this has been of some interest and more so of some value, and will prove to be of some value in your work with your patients. To summarize briefly, major depressive disorder is truly one of the world's greatest public health problems. The World Bank now rates it as the world's #1 public health problem. Prompt recognition, vigorous treatment, and careful follow-up represent the best ways to reduce the burden of MDD. We have many effective and well-tolerated therapies, pharmacologic as well as psychotherapeutic. However, a significant minority of our patients don't respond to our first chosen first-line medication. Whether we use an alternate as a second-line choice, or whether we move on to various adjunctive or combinatorial strategies is a matter of the art of practice. There is evidence to justify each of these practices. And when we get the patient better, we move into models of continuation and maintenance phase treatment, which represent the best way to maximize our patients' chances for a sustained recovery. So thank you so much for your kind attention. Kostas, welcome back. How many minutes do we have left for questions and answers?
We have as much time as we like.
Okay.
Michael, I am very glad that you brought the tachyphylaxis issue, and it's the second major thing that was here today. Siegfried has discussed the issue that the presence of anxiety is related to more severe forms of depression. I didn't comment on that after his speech, but anyway, these are two major issues because we used to think psychoanalytically that anxiety is something like an effort to compensate for depression or to self-treat depression. And anxiety is related to less severe forms of depression. But we knew since the epidemiological catchment area results that anxiety goes with more severe depression.
Yeah.
So it's not that when you see anxiety, you do not push pharmacological treatment. You should push pharmacological treatment when you have anxiety. Of course, anxious patients want to talk more than non-anxious patients, but this should not preclude biological treatment. And then you bring up the tachyphylaxis. I completely agree that it's a placebo effect. And you didn't say that 1/3 of the study patients that originally responded to treatment, after I think 3 or 4 months, they relapsed, which was probably a placebo effect in the first place. Probably.
Well, yes. So when we do our survival analyses of groups that stay on drug versus groups that fail on placebo, you see a separation that more people relapse on placebo than relapse on drug, but about 10 to 15% of the people relapse on drug, even when they're adherent. But if you work the proportions, and you assume that the placebo effect is hidden within your drug effect group, you can explain apparent tachyphylaxis as the loss of the placebo effect. Because if the drug wasn't really an effective drug for you, it was just something you took while you were getting better with the help of your kindly pharmacotherapist and improvements in your life and so forth. But then, life's hard. You get fired from your job, or your spouse runs off with somebody, or your children behave badly, or whatever. You become depressed again because the medicine won't protect you if it never helped you in the first place.
Just for the audience to say that this is a very important issue, because if the so-called additivity hypothesis is correct, that is, response to medication is response to placebo plus response to medication. This is quite different to say that, okay, there is no placebo at all within the medication response. This has a number of consequences concerning biological research, concerning the way we interpret things, concerning the way we interpret our patients, not only trials, but our patients themselves. We have 2 questions. The first is whether Ascatamine can be used in the way ECT is used. Yes, I think this has been already answered. And whether do you think that rTMS is an alternative for the treatment of resistant depression?
Yes, it is about as effective as a tricyclic or an MAOI or a 2-drug combination for someone who has not responded to 2 or 3 lines of conventional therapy. So your patient has about a 30, 40% chance of having a nice response to it. The thing I like about TMS the most is how well tolerated it is. And so for patients who have had a bad time with side effects, I think it is a treatment that works through an entirely different mechanism of action, and it gives them a fresh chance, basically. I would not do TMS for a very, very severe or very disabled, depressed patient. It just doesn't work enough when we have ECT or ketamine, S-Ketamine available as alternatives.
We have a second question, which is again on the same tachyphylaxis expectancy thing with the placebo. Do you believe that the complaint of lack of efficacy of antidepressants is due to the distorted belief that they should permanently feel good? If not, what percent do you believe is due to this reason? The expectancy.
Oh, yeah. So this is when I talk about psychoeducation. I think you want to start out with reasonable expectations. And so when I teach our residents and medical students about the art of caring for people, you want to tell more than the truth about side effects. You want to make sure your patient is well versed on what might happen in those first few weeks of therapy. And you want to undersell. I hope this translates well. You want to be brutally honest about the chances of benefit. And so I tell people my patients have about a 60% chance of getting better, because they do, because I take good care of them. And but maybe yours have a 50% chance, or whatever you think it is. You say, I think you have about a 50-50 chance that this is the right medicine. And if that's the case, you will slowly feel better over the next few weeks. We might know early on it's the wrong medicine for you if you have too many side effects or it's not helping you a bit. But if you start to feel better, we're going to give it 6 to 8 weeks to work. And the best that can happen is that you will feel exactly as good as you felt before you were depressed. No better. And these are unlike any intoxicating medicine you've ever taken. That it will not make you feel happy. It will not make you feel less sad in the moment. It will simply help you return to feeling the way you were before you became depressed.
My experience says that those patients that they probably would be most benefited by psychoeducation or by psychotherapy, unfortunately, they are not suitable for psychotherapy. I mean, there are a lot of patients that you really need to talk to them out a lot of problems.
Yeah.
And if
some
you don't
people
do
have
this,
no talent. They have no talent for psychotherapy. It's true.
but it's impossible.
Yes. So then I think maybe I can be like a coach, like a coach at a health club, where I can at least coach people on doing some of the things that non-depressed people do that are associated with feeling less depressed. But there are some people who are uncoachable, right? So there are people who are truly difficult to treat. And you just, if you can't work with someone, you should find them a different doctor or a different person, because when your own psychiatrist gives up on you got no hope. And so once you get to the point that you think this person's untreatable, that's when you need to transfer care if you can. Kostas, I see a couple questions that have popped up that I can answer if you don't mind me.
Yes, please do.
One is about agomelatine. I have never prescribed agomelatine because it was not even in clinical studies in the United States. I believe it was a Servier drug, wholly owned in France, and they made a decision not to bring it to the United States. And
Siegfried was part of the trials in Europe, I think.
Yeah, but I know the data, and I mean, I'm a citizen of the world. I read the data. I wish we had it. It is an effective medicine that has useful effects on insomnia. So it complements what we have with mirtazapine, although agomelatine doesn't have the weight gain risk or benefit that mirtazapine has. I've seen the comparative data. It is nearly as good as your favorite SSRIs or SNRIs, and won a few of the head-to-head trials. I think it was more effective than venlafaxine in one of the European studies, primarily because of its beneficial effects for sleep. Now, there was another question. Have there been any head-to-head studies of S-Ketamine and ECT? No. But there is a head-to-head study of intravenous ketamine and ECT in Sweden, as well as studies underway in Europe and in the United States. The Swedish data were reported in the published literature just a few months ago, and there was a fascinating finding, and that was that across all age groups, ECT was about 15% more effective than intravenous ketamine. So a modest win for ECT, right above the threshold for significance. But when they divided the sample by age, there was actually a treatment by age interaction, and ECT was way superior to intravenous ketamine in the older patients. And intravenous ketamine was actually somewhat better than ECT in the younger patients. And I do not remember, it wasn't my study, I don't remember where they drew the line on age, whether it was 50 or 60. But if you'll remember, in the esketamine registration studies, they could not show a significant effect in older patients with esketamine either. So an interesting finding. I certainly would want to do intravenous ketamine or esketamine myself ahead of ECT if I was in a depression. Now, if I was psychotically depressed or if I was grossly impaired, I hope my family would pull me over to the ECT side of the decision making. But I think there's room for both of these treatments, and they have complementary effects. The only sad news I have to say here is that you can't use intravenous ketamine or S-ketamine as your anesthetic for ECT, because higher anesthetic, fully anesthetic doses of these medicines do not have the same antidepressant effects.
But if I may comment on this, depends on the patient sample, not only the age, but the degree of refractoriness. Through the years of my clinical experience, and because of ECT was not available always, we are pushing antidepressant dosages to the highest limit, and beyond this, up to, let's say, 450 venlafaxine, plus,
yes.
Plus, super refractory patients. I think that above 300, there is no meaning to titrate further. But I can say this now after so many years. Anyway, these super refractory patients to antidepressants and combination treatments, in my experience, do not respond at all to ECT. Typically, refractory patients which had not responded to one trial of 20 milligrams of fluoxetine and then to a second trial of 150 milligrams of venlafaxine and then to 20 milligrams of escitalopram. These typically refractory patients, they do respond to ECT, but these super refractory patients do not. But we recently developed an S-Ketamine nasal spray, S-Ketamine unit, and we have our first 6 or 7 patients from these super refractory patients. These super refractory patients do respond to S-Ketamine. We haven't tried ECT to these specific patients, but from my experience, this group does not really respond to ECT. They seem to respond not optimally, but at least 50 to 60%, and with some kind of unstable response, but they do respond. So it depends.
I was going to say we have those patients in the US. Yes, they are in the US too. They often need to stay on twice a week treatment. You can't get them to every other week or even weekly treatment sometimes. And I think this is a group for whom some kind of rehabilitation model therapy in terms of learning to live in your somewhat improved state to make a better life may be valuable. And because I think the answer is not just simply in twice a week nasal spray for the rest of your life. It may be in making use of the modest improvement you get with the nasal spray to work on other ways of keeping yourself out of the disabling parts of the depression.
I think we need to
So
discuss this further.
I must move on. I am scheduled on the back end of this.
Okay.
So I really do appreciate the chance to talk with you all today. And I look forward to the next time, maybe doing it in person. So
Siegfried, are
thank
you
you so
here?
much.
Siegfried, are you here? Anyway, thank you, Michael. Thank you, Siegfried. Thank you, all of you, for being here with us tonight.
There he is. See, he did not leave us. Bye-bye.
Take care until next time. Bye-bye.
Bye-bye, bye-bye, bye-bye.